Good afternoon, ladies and gentlemen. My name is Pandu Karnanayaka and my co-chair is Dr. Sri Lanka. We have come to the last two sessions of our sessions, which are going to take place in parallel. This is Hall A for infectious diseases, and on the other side is Hall B for endocrinology. So welcome to this session. We have three very interesting speeches on infectious diseases. One from overseas from Dr. Nick Beeching, and the other two from local experts. So without any further ado, let me introduce Dr. Nick Beeching, who is actually no stranger to Sri Lanka. He has been here more than a dozen times. He is now retired, but he till this year, he was a senior lecturer in and consultant in tropical medicine and infectious diseases at the Royal Leopold University Hospital and the Leopold School of Tropical Medicine. And Nick is going to talk to us about a very important topic because, unfortunately, it's becoming now identified in Sri Lanka, namely meningococcal infections. So over to you, Nick.
Well, good afternoon, everybody. My name is Nick Beeching from Liverpool, and thank you very much for inviting me to join you on this last day of the conference. And I'm really sorry that I can't be there in person to meet with you and catch up with many friends and colleagues. I'll just share my screen with you. I have a short space of time in which to talk about meningococcal infections. So without further ado, I will do so. Just to give you an idea of the plan, I'll talk about some clinical presentations, then a little bit on microbiology, quite a bit on epidemiology, some key pointers in diagnosis and management, and finish off with prevention, both chemoprophylaxis and vaccines. Just imagine this is a patient seen in Liverpool, in Britain, call from the GP to the unit, who's just been called to see a male student in October, soon after the beginning of term, with a one-day headache, and the student is drowsy and doesn't like the light. What advice would you give to that general practitioner? I assume that you would want him to send the patient in for admission, but of course you should also advise immediate antibiotics. This is quite an old paper from 2006. The evidence base isn't marvelous, but it's still considered to be good practice and potentially life-saving to give early antibiotics. Don't worry about obscuring the diagnosis. CSF will stay abnormal for at least a couple of days. Much more important to give an antibiotic. So this young lad arrived in hospital 45 minutes later. There was nothing else significant in his history. He was a bit drowsy, high temperature and tachycardia, but not frankly septic in the old-fashioned sense, had mild neck stiffness and photophobia and the emergence of a rash. And the presumed diagnosis was meningococcal meningitis. Again, what tests would you do? What are the important tests that you would do? How would you manage him? And what would you do about his contacts? This was his rash, which became more florid over the next few hours. And indeed, the important answer to the question about management was do blood cultures, establish an intravenous line for more antibiotics, and do an immediate lumbar puncture, which showed typical features of pyogenic meningitis with raised neutrophils, slightly raised protein, and a reduced sugar compared to the blood sugar. Gram stain shows gram-negative diplococci in clumps here, individually there, and even within the neutrophil, so very straightforward, and he did extremely well. Another patient I came across in New Zealand quite a while ago now, again a young Maori man who had a few beers on Thursday night, woke up with a headache the next day, and thought it was due to too much beer, but actually became very ill over the next couple of hours, came into hospital at 10 in the morning and was dead by 6 o'clock that evening. And you can see these florid petechiae, which you could almost see coalescing in front of you. He had an autopsy which showed similar features in his heart, and other tissues, and indeed in the adrenals. And this is fulminant meningococcal sepsis, or what used to be called the Waterhouse-Friderichsen syndrome. Finally, another patient, when I was in Auckland, there was an epidemic of group A meningococcal infection at the time. This was a middle-aged woman towards the end of first week of quite severe disease with adult respiratory distress syndrome resolving. She'd just been taken off a ventilator, and indeed she had quite bad necrosis of tissue in her limbs and around her mouth, which fortunately all resolved. So what's the cause of this? This is the meningococcus, or Neisseria meningitidis. You've already seen the gram-negative diplococci with big, juicy polysaccharide capsules, which can be used to divide them into different strains. And there are about 12, of which 6 are most important, the ones that you can see here. We now also use whole genome sequencing or other forms of molecular testing, and we can show that there are different clonal complexes which may express different capsules, capsular polysaccharides, which is confusing, but we're now beginning to recognize the emergence of particularly aggressive clonal complexes, especially ST11, which has crossed over into Africa and to the UK and is also present in China, and is now becoming associated with some penicillin resistance. Normally, people carry these in the nasopharynx, maybe 10% of children, with a higher percentage in young adults, and of course, much higher during epidemics. And the meningococcus is well adapted to the nasopharynx, but under stress, things like other infections, common cold, influenza, smoking, being exposed to wind with a lot of sand in, anything that irritates the nasopharynx may promote translocation into the bloodstream. Pyogenic meningitis is a common cause in the pre-vaccination era of pyogenic meningitis, and the mortality should be under 10%, as opposed to the fulminant sepsis syndrome I presented, which can have a very high mortality even with excellent treatment. Just to mention a couple of other presentations, there have been reports of sexual transmission of meningococcus. It's present in saliva, and outbreaks of proctitis and urethritis in men who have sex with men in the USA, and occasional cases of conjunctiva when saliva gets in the eye for some reason. But the usual features are sepsis or meningitis. The different capsules, capsular serotypes have traditionally been associated with different parts, B and C endemic in Europe, B and C again down in Australasia, New Zealand, and Australia, and typically group A in sub-Saharan Africa, which I'll come back to in a minute, but emergence of other strains. What I want you to notice is the big gap of information here. Certainly there have been epidemics of group A in North India and perhaps A or C in China, but no data for Sri Lanka. In addition, in the epidemic belt of sub-Saharan Africa, you can see here, it was recognized by this French army physician long time ago that there were recurring epidemics every 5 to 7 years of what was usually group A meningitis. More recently, other strains have become more important, which has great implications for immunization programs, including W135 and other strains. And during epidemics, the incidence of disease may be 100-fold what it normally is, and there's a shift to older age groups being infectious, whereas in an endemic setting such as the UK, before we had immunization, it was younger children who were the highest risk group. So when I left Saudi Arabia in 1987, I worked there for a couple of years in a plane just like this, going over this Hajj terminal. There are a large number of Hajis who just done the Hajj were coming back. And some of them were carrying this group A strain, which originated in Nepal in the early 80s, got to India in the mid-80s, and Mecca in 1987, then spread around the world. Since then, the Saudis have introduced compulsory immunization. Initially, it was against Group A, and then in the year 2000, this previously rather obscure strain W135 emerged as an important cause of Hajj-related meningococcal infection. And these are just the cases imported into the UK in the following 2 years. I think this demonstrates the importance of knowing the epidemiology of infection and being able to initiate appropriate control measures. And of course, those going for Hajj and Umrah now have the quadrivalent vaccine against several strains. Within the UK, the purple, these are in children. So you can see meningococcus accounts for a fair amount of pyogenic meningitis. In the States, it's this light gray area, again, in young children, not very prominent, but up to in adolescence, about similar to the pneumococcus, which is brown here, whereas in adults, pneumococcus predominates. But again, we've seen the emergence of this serogroup W disease in the UK, emerging in the about 10 years ago with rather atypical and aggressive presentations that you can see on this slide. And this became particularly noticeable in the media, and we have now altered our immunization schedule to give a quadrivalent vaccine, including this strain W. What about Sri Lanka? They don't feature. This is a huge initiative, the Global Meningococcal Initiative, aiming to trace different strains and clones of meningococci around the world, but especially to underpin control and perhaps elimination programs. But virtually all of your neighbors are represented in this new initiative, but Sri Lanka is not. And here's just an example of the sort of graph they can produce, the different strains, the South American lineage, a Hajj lineage, the UK strain, and this kind of molecular detective work is very important. Okay, moving back to the directly clinical applications, what about diagnosis? Just a few clinical pictures of the rash, which may be a very fine purpuric rash, and typically comes after the junior doctor admitting the patient has seen the patient, and then the boss comes along and says, oh, well, here's a typical rash. So it can develop very fast, and re-examination of patients is useful. It then may become more prominent. This was an older patient in Liverpool. This was referred as a possible battered baby, in fact, but turned out to have quite severe meningococcal meningitis. You can see the neck retraction. I'm glad to say he did very well. Occasionally, it can affect the bulbar conjunctiva, or rather unusually in this older woman, the palpable conjunctiva. So it's worth examining the patient all over these clinical features, which are strongly suggestive in this context of meningococcal disease. A little bit more difficult to see on dark skin, but this is a Malawian NAD where these are quite prominent and very obvious in this Brazilian boy with purpura fulminans, and unfortunately not such a good outcome. We've also seen this in older patients. You have gangrene and loss of digits or even limbs. As a result, this is not always meningococcal. And just be aware, this is Streptococcus suis, the most common cause of pyogenic meningitis in Vietnam. And similar picture seen with pneumococcal sepsis complicating sickle and C hemoglobinopathy in a young African. We've even seen it and reported cases of chikungunya in children in Karnataka state in South India. However, this is usually meningococcus, as in this young Sierra Leonean woman whose legs you can see here. So having suspected it clinically, of course, you should do blood cultures, which may be negative if the patient has already had antibiotics, as may the cerebrospinal fluid. And here, the introduction of PCR on both blood and CSF has greatly improved the sensitivity of diagnostic tests. You should do a lumbar puncture. Biochemistry, gram stain, and culture is important, but for both the strain and the sensitivity. Rapid diagnostic tests have been rather disappointing so far, but there are improved ones coming along. Management essentially is early recognition. Just to remind you, in the pre-antibiotic era, this is 1900 going across to 2000, the pre-antibiotic era mortality was around 80%, so 20% survived. And then with the introduction of serotherapy, which we don't use now, that's serum from recovered patients or from horses, actually reduced the mortality to around 25–30%. And then as sulfonamides were introduced in the 1940s, reduced to about 10%. We haven't improved things much more. But using algorithms like this for early recognition, instant action, as the patient, before the patient comes to the hospital, as the patient hits hospital, is really important. This is an example from Britain, from the British Infection Society, together with other august bodies. Not going to go through the detail of that now, but you should have this sort of protocol, because the earlier you treat, the better the outcome with any form of pyogenic meningitis. Which antibiotics can we use? Penicillin resistance is only just beginning to emerge, and we have to watch that. So you can still usually use high-dose penicillin, either recurrent dose of penicillin G or depot preparations such as benzathine or triplopen. Chloramphenicol, or a rather outmoded depot preparation called tifamycin, also works and is particularly useful in resource-poor settings. Most of us would use a third-generation cephalosporin at the moment. We still don't know how long treatment has to be given for. We probably overtreat, and in epidemic situations in West Africa, a single dose of depot of chloramphenicol or triplopen was adequate for the majority of patients. Typical recommendations in the UK would be for 5 or perhaps up to 7 days. We now recommend 5. But again, just going back, during that epidemic in New Zealand, a subsequent epidemic in New Zealand, adults were treated with just 3 days of penicillin, and their outcomes were as expected. And of those that died, 4 died while still on treatment. In other words, they would have died whatever the duration of antibiotic therapy. So we should be looking to shorten antibiotic therapy, and some patients may even be suitable for outpatient antibiotic treatment, which is something I'm not quite brave enough to do yet, but other colleagues in the UK have been doing. The really important thing is to go back and reassess your patients. If they're doing really well, you can have a shorter duration of treatment. Follow-up is also important. We sometimes fail to appreciate that this can cause quite significant deafness, and we would encourage follow-up of all patients after 4 to 6 weeks to make sure their hearing is okay. Contact management. Generally, we give close contacts, that's household contacts and kissing contacts, but not medical staff unless they're somebody like an anaesthetist getting aerosolized material in their face, a single dose of ciprofloxacin. Other alternatives are ceftriaxone, especially for pregnant women, or rifampicin. But the evidence base is not marvelous. Again, the BMJ 15 years ago, suggesting that you need to treat 200 people to prevent 1 case in contacts in 30 days. Nevertheless, ciprofloxacin is fairly easy to use. In larger outbreaks, mass chemoprophylaxis has been shown to work. A variety of drugs have been used. We used to use sulfadiazine, but now there's a lot of antibiotic resistance to that, and minocycline is very difficult. So again, it's primarily Cipro, but we are beginning to get worried about the emergence of Cipro resistance, particularly where it's used a lot in prophylaxis for the Hajj. And so we need to watch this space. What's the situation in Sri Lanka? This is the latest information I could find. It's dated 2011, and here are the doses. And you can safely use single dose of ciprofloxacin in children. We used to worry about effects on cartilage, but that's not been a real issue in the real world. So finally, just a couple of minutes on vaccines. There are two main aims of vaccination. One is to prevent carriage in the nasopharynx, and hence to prevent infectivity to others. And this is particularly important in the context of epidemics, such as the ones we see in sub-Saharan Africa, where rates of carriage can be enormous and clearly need to be reduced. And also, we want to prevent disease. Older vaccines were based on the capsular polysaccharide. They're strain specific, so you had to have different vaccines for different strains. There were big issues with cold chain maintenance, poor immunogenicity, and poor duration of the immunity. This is greatly improved with the introduction of conjugate vaccines for these 4 strains, and now also for strain X over the last 15 years. And the new ones on the block are outer membrane protein group B vaccines, which was a big gap until just a few years ago. So just to take an example from Britain, the introduction of group C conjugate vaccine was the proof of principle, which is highly successful. You can see within a year of introducing them, 80% reduction of clinical disease. If you look at the cohort effect, there is also huge herd immunity, so that unvaccinated, this was the attack rate in 1998 to 1999. 2 years later, in those vaccinated, virtually nil, but even in the unvaccinated group, a huge reduction in incidence in disease. And so this showed that you could reduce both carriage and infectivity and even more so disease in those that were vaccinated. So the vaccines on the block now are especially the quadrivalent vaccine for ACWY. This is a conjugate vaccine, and there is now a pentavalent one, which includes X. The game changer for Africa was this vaccine produced in India, and then Afrivac, which is conjugated meningococcal A conjugate with tetanus, toxoid, and other things. And then more recently, 2 different group B vaccines. In the UK, we've now very recently introduced group B vaccination for babies, and then boosters for university students we're using the quadrivalent vaccine. So as I mentioned, meningococcus W has come along in the last few years. And so here is a British meningococcal regimen with 3 doses of group B by 1 year, meningococcus C associated with Haemophilus, and then boosters against C as a teenager or university. But I gather this is not yet done in Sri Lanka. So the introduction of this conjugate group A vaccine in sub-Saharan Africa across this meningitis belt, proof of principle was about 10 years ago, showing a 71% decline in meningitis and 2/3 decline in fatal meningitis. This has been absolutely fantastic, and follow-up studies have shown that this is maintained and probably reduced meningitis due to that strain by about 90%. However, other strains are coming in, and there is still possibly a place for mass chemoprophylaxis. And this prospective study showed that single dose of Cipro given on a village-wide basis could more than halve the rate. So probably a combination of vaccination and mass prophylaxis in this setting. So just to finish off, for you, certainly a substantial number of Muslims who will want to perform Umrah or Hajj in Saudi Arabia. So they're your travelers that will need immunization against meningococcus. But do you know enough about what's in your country? There are guidelines, British ones, European ones, to help guide you on the management of meningitis and meningococcal sepsis. But the Global Meningococcal Initiative has a number of recommendations, which I'm not going to read out, but just say the ones I think that matter for Sri Lanka particularly. Do you know enough about your local epidemiology? Are you vaccinating all high-risk travelers? And how good is your laboratory-based surveillance to determine whether immunization is needed? So I've used up my time. Thank you very much for your attention. And I hope there will be time for a little bit of questions.
Yes, I think we can leave questions till the end, and let's move on to the next speaker. He's Dr. Samantha Nadika Janagi. He's a consultant medical virologist from MRI. Dr. Janagi is going to talk to us on spectrum of CMV infection. Over to you, Dr. Janagi.
Thank you very much. And I'm thankful to the Ceylon College of Physicians for giving me this opportunity. My topic is spectrum of CMV infections. CMV is a herpes group virus which has the latency phase in leukocytes. Unlike other herpes viruses, it is in blood. The latency also in blood. Therefore, there is a tendency for reactivation of CMV in blood time to time. So CMV IgG is a serological marker for the exposure for this virus. If somebody is CMV IgG positive, that means that person is having the CMV virus inside his leukocytes, potential to reactivate at any time. And also this virus can be excreted in saliva and urine. And this is thought to be a very ubiquitous virus, seroprevalence ranging from 40% to 100% worldwide, mainly in developing countries. Almost all population is infected, and in developed nations, it is about half the population infected. So that means in developed countries, about half the population is at risk of primary CMV infection if they are going through any vulnerable period of the life. There are several modes of transmission. Mainly it is person-to-person contact by close contacts from the people who are excreting the virus in saliva and urine. Sexual transmission and also mother-child transmission. Then blood and organ donation also can transmit the virus. So therefore we have to remember one specific point here. Vulnerable population, mainly immune compromised people with transplants, we may need to consider leukocyte depleted blood in transfusion to avoid CMV complications in them. So there are different clinical entities with regard to CMV. One main entity is congenital CMV, which is not the interest of this audience. Then CMV infection in immune competence. It's mostly not a very significant thing. Most of them are asymptomatic, but some may present as infectious mononucleosis-like syndrome. Then the most important clinical entity with regard to CMV is opportunistic CMV infection in immune-compromised people, including transplant patients, patients who are under chemotherapy, cancer patients, and HIV patients. So there could be three different scenarios in this population, like just CMV infection only without having any symptom, or infection with symptoms in two main clinical entities called CMV syndrome and CMV disease. Another thing is this infection can be primary infection or recurrent infection. The primary infection is the most risk infection for vulnerable groups, giving rise to complications. Recurrent infection is also there with the reactivation of all latent virus or getting infected with a new strain of virus from outside source. In immune competence, mortality is not that significant with regard to CMV, but morbidity could be sometimes impact could be there with the morbidity. Like infectious mononucleosis, there can be prolonged illness with significant morbidity, but mortality is not that much important. In case of immune compromised people like transplant patients, mortality is substantial with regard to CMV opportunistic infections as well as morbidity. One example is in allogenic bone marrow transplant patients who develop interstitial pneumonia, the mortality rate range from 15 to 75% despite specific antiviral treatment. So once this immune compromised population gets the CMV disease, it is very difficult to treat and get favorable outcome. We'll first go through some clinical entities in immune competence. So mainly infectious mononucleosis, mostly asymptomatic, but some can develop infectious mononucleosis. It can present like flu or infectious mononucleosis driven by Epstein-Barr virus, or it can present like hepatitis. This mononucleosis syndrome can have a range of clinical symptoms, including liver and spleen involvement, skin rash, and fatigability, or they can present like hepatitis. So we can see there's a range of organs involved in this infectious mononucleosis in immune competence, including colon even with diarrhea and encephalitis. And there could be multi-system involvement, and this is a DD for fever of unknown origin in our clinical practice. So what is the significance of pneumonia in these immune competent people? So actually it is thought to be not that much clinically important, because it can be only prolonged fever with less respiratory symptoms, but having some radiological findings of lungs with some changes in lymphocytes and mild transaminitis. Most of them recover by their own without any specific treatment. Now, the main question here is whether we need to treat CMV pneumonia in immune competence when we come across. There are no such guidelines, and generally we don't need to treat. But in literature, there are case reports where this kind of the people who have developed severe pneumonia or protracted disease have been treated with specific antiviral treatment and got favorable outcome. But it should not be overgeneralized. The here main challenge is that when we come across a patient with pneumonia who is thought to be having IMN, it is sometimes difficult to identify CMV as the exact cause for pneumonia. That is one challenge. The other challenge is these specific antivirals are highly toxic, can give rise to marrow suppression. And if the pneumonia is due to some other pathogen, you might be by giving antivirals, the patient can be getting more harm. So therefore, we need to develop ongoing evidence with regard to this clinical entity, but there is an option of treating when we come across very definite pneumonia due to CMV without getting resolved in case basis. The incidence of pneumonia is around 6% in IMN, and it can go up to 19% according to some literature. But luckily, most of them are self-limiting. We don't want to worry. Like in CMV pneumonia in immune-compromised people, where it is a life-threatening condition. So what is the laboratory diagnosis for CMV IMN-like syndrome in immune competence? It's mainly based on serology, CMV, IgM and IgG, and in parallel, we manage to do EBV serology as well. In EBV, IgM, IgG, and also we can use anti-nuclear antibody also for retrospective confirmation. The place of CMV PCR in immune competence to diagnose the disease, it is generally, the PCR is generally reserved for immune compromised patients, not generally used in immune competence. But in rare cases where you are very much doubtful about your diagnosis, and if the patient is having prolonged illness and having complications, then still we can use this tool also for diagnosis in case basis. So then we'll move on to main clinical entity with greater impact on patient population, CMV in immune-compromised patients, including transplants, cancer patients, HIV patients, and primary immune deficiency patients. So actually, this CMV infection is controlled by our cell-mediated immunity efficiently. That's why we are not worried about this infection in immune competence. But when patients are deficient in their cell-mediated immunity, they are at greater risk of getting complications due to CMV infection, especially with primary CMV infection, as I told earlier. So when we detect CMV viremia in immune-compromised people, transplant patients, it can say different things. The one thing is that we may be detecting incidental viremia, which is not of clinical importance. Sometimes this CMV viremia may be predictive of pending CMV syndrome, CMV disease, which are great impact for the patient's outcome. If the patient is already having symptoms, this CMV viremia may be associated with disease itself already. In managing immune-compromised patients, it is very difficult to distinguish between these three entities when we want to find the cause for the symptoms. So CMV syndrome is a well-defined condition among mainly solid organ transplant patients. It is mainly fever with marrow suppression with neutropenia or thrombocytopenia and detection of CMV in blood. In bone marrow transplant patients also you can get the same condition, and it can be caused by other viruses other than CMV. So CMV disease in transplant recipients. It is also called end organ disease. CMV is thought to be excreted in saliva and urine, even in immune-compromised, immune-competents also. Even in immune-compromised, it is not a greater concern. We are not that much worried about CMV excretion in urine or saliva. But if we detect CMV virus in blood in transplant recipients, that is a significant finding, because that may be predictive of pending severe illness in that patient. They say that the sensitivity of CMV viremia as a marker of CMV pneumonia is 60 to 70% in allogenic bone marrow transplant recipients. And having no evidence of virus in the bloodstream has a high negative predictive value for CMV disease. So in this background knowledge, we have a concept of preemptive therapy in transplant population with regard to CMV, which is a new concept with regard to medical practice, which is coming under transplant medicine. So here, what we do is, after organ or stem cell transplant, we have to detect the CMV activity of transplant recipients using real-time CMV PCR. There we have to quantify the virus and weekly follow up the viral load to see the trend of infection, to detect whether this viremia is significant enough to give rise to pending disaster in these patients. So if we think that according to our criteria, this significant viremia is there even without having symptoms, we might need to start therapy on these patients with antiviral IV ganciclovir, oral ganciclovir, and foscarnet would be a second-line therapy. So here the concern is, if these immune-compromised transplant patients get the disease with CMV, it is difficult to get any favorable outcome even with therapy. So idea is to, before getting symptoms, detecting the significant viremia and treating it before the disease for the favorable outcome. At the same time, we can't go on treating these patients very loosely, like giving antibiotics, because these antivirals are highly toxic. They are marrow suppressive, renal toxicity also there. So therefore, if we are giving this antiviral to an incorrect patient, where there is no indication for CMV treatment, we might be doing more harm to the patient's condition. So that's why the concept of preemptive therapy is there, with very close monitoring of viremia using CMV PCR. Pneumonia and immune compromise from CMV is a very aggressive condition. If we detect CMV infection in bronchoalveolar lavage or fluid, then with pneumonia features, it might be suggestive of pneumonia. But we know that that sample is not a very freely available sample for testing. So sometimes we have to test blood. And as I earlier said, blood also may be predictive of CMV pneumonia if the patient is having symptoms. And here the context is a bit complex. In different immune-compromised people, the detection of CMV might give different readings. For example, in HIV or AIDS patients, if we detect CMV with pneumonia, at the same time, if we detect Pneumocystis carinii in our investigations, the most important pathogen would be Pneumocystis carinii. Sometimes if we treat Pneumocystis, patient recover from that treatment without treating CMV. So therefore, in case of HIV patients, sometimes CMV detection might not be the significant cause for the existing disease. Therefore, we have to be careful in deciding in our treatment. But in case of transplant patients, if we detect CMV in blood, it is more significant than in case of HIV. Actually, the CMV disease risk among transplant recipients may vary according to the type of transplant, because different transplant have different level of immune suppression. Mostly bone marrow transplant recipients and lung transplant recipients are at risk of getting CMV disease with adverse outcomes. So therefore, in managing immune compromised population, clinical significance of detection of CMV infection can be doubtful when co-pathogens are detected in that population. So it is not very straightforward always. That's why we have to always go with laboratory investigation results with CMV quantification, and we have to monitor the trend of the infection before making the judgment. As I told earlier, established CMV disease is difficult to be treated even with specific therapy. Therefore, we go with the preemptive therapy with preceding viremia. And that viremia is a good indicator for pending disease in transplant patients. And we sometimes combine not only antivirals, it is with specific immunoglobulin for the treatment, and that combined therapy seems to be having better outcomes. So in addition to pneumonia, in immune-compromised people, there could be other CMV diseases or end-organ involvements, including hepatitis, and GI tract can be involved from top to bottom, giving rise to various symptoms. Actually, in diagnosing colitis, we can't confirm or exclude colitis by doing CMV PCR in blood, because it might not be represented in blood, or there could be incidental CMV infections without being the cause of colitis. So there we have to go for colonoscopy and take multiple biopsies to see the tissue activity of CMV without relying on blood results. CMV retinitis is a significant disease in HIV patients who are having low CD4 counts. And also, when they are treated with highly active antiretroviral therapy in the background of CMV, they can have iris, the retinitis due to iris in HIV patients who are on treatment. And also there could be encephalitis or neuropathy also with regard to CMV infection in immunocompromised. We have seen severe encephalitis in some HIV patients, even in some cases. And in such situations, CMV can be detected in high copies in CSF. So these are some other rare conditions even can happen in immunocompromised patients. So what is the risk of CMV disease in transplants? It would depend on several factors like the type of transplant, level of immune suppression, the type of induction therapy, and HLA mismatch. All those play a role. In addition, the CMV serostatus between recipient and donor also very significantly affect the outcome of CMV disease. If the solid organ transplant recipient is CMV seronegative and the donor is CMV seropositive, that means that negative recipient can get the primary CMV infection after transplant and at risk of adverse CMV outcome. With regard to bone marrow transplant, it is other way around. And always CMV viremia is a significant predictive indicator for pending disease with adverse outcomes. And also we know in bone marrow transplants, there's a condition called graft versus host disease, which can be precipitated by many factors, and CMV infection also one of those factors. So far I described you the CMV direct effects on immune compromised patients. In addition, there are some indirect effects of CMV on transplant recipients. That is, at the time of outcome, there might not be CMV infection, but due to recurrent CMV infection, due to recurrent preceding CMV infection, transplant recipients can develop different sequelae, like they can have atherosclerotic changes giving rise to MI events, and there could be CMV-driven immune modulations giving rise to other secondary bacterial infections. So therefore, these indirect effects also very much significant in transplant population. And in that case, universal antiviral prophylaxis for CMV might be beneficial to avoid these indirect effects also at the expense of antiviral toxicity. So if we are to give prophylaxis, then the patient may need to bear with the adverse toxicities, and we might not be even able to continue sometimes due to the toxicity. So this is a balance of different pros and cons in management strategies. So antiviral therapy is mainly IV Gancyclo and oral Valganciclo in first line. In second line, with if we suspect resistance, we can go for IV for Scarnat. And as I said you earlier, the all associated with high myelosuppression and renal toxicity. Some most difficult to continue full course of treatment in these kind of patients because they are developing toxicities in the middle of treatment. And also we can combine specific immunoglobulin to antiviral for better outcomes, especially in CMV pneumonitis in bone marrow transplant. And also it is all used for prophylaxis purposes as well. Then other condition now we have come across is we tend to see CMV infections in patients who are admitted to ICU due to some other conditions and who are not having a past history of immune suppression. So they are normal healthy people before this event, and when they undergo ICU care, we have seen CMV infection in such patients. And this is a area, this is a gray area where we need to develop further evidence. In some literature, they say this is significant. In some literature, they say this is not significant. The idea is whether this is just an incidental finding with regard to underlying condition, whether there could be CMV reactivations as a result of the condition, or whether this CMV reactivation is contributing to the existing pathology and might be giving out adverse outcome. So therefore, would it be useful to treat this CMV infection with toxic drugs in such patients is a dilemma still. So therefore, we might need to develop ongoing evidence with clinical practice and case-based trials in such scenarios. So that's all, and thank you very much.
Thank you very much, Nadika, for that very comprehensive coverage of CMV disease as well as diagnosis. Can I ask my co-chair, Dr. Luatage, to offer a token of our appreciation to you? And also come and join us at the head table. Ladies and gentlemen, those of you who are joined in online, just a reminder that you can type in any questions that you might have to our panel into the chat function of the Zoom that you have. And also, if we do have time in the end, we will have those questions entertained. Let me now introduce our third and final speaker, Professor S.A.M. Kularatne, Professor of Medicine from the University of Peradeniya, who will speak to us about another very important topic for us, Rickettsial infections. Professor Kularatne, sir.
Good afternoon, ladies and gentlemen. First of all, let me thank the Ceylon College of Physicians for extending this invitation to talk to you on Rickettsial infection in this symposium. The Rickettsiae has a long history. This slide shows you one of the earliest publications on Rickettsiae that is very much popular as typhus fever. That was in 1822. If you take Rickettsiae, it is a global disease. It has a global distribution. All these arrows shows in the global map where the Rickettsiae are. Even in India, it is there, but the time it was Sri Lanka, it is not shown here. But when you take Sri Lanka, the Rickettsiae is quite common. It has re-emerged. So these two maps show you in just 4 or 5 years, there's a huge increase in number of notification of Rickettsial infections from all over the island, more from northern sector and even in the southern sector. First of all, consider about the historical aspects of Rickettsioses. In the history of Rickettsioses, there are 3 Rickettsiologists. They have 2 reputations because 2 these pioneering scientists died of Rickettsial infection, and 1 scientist won the Nobel Prize. So Charles Nicolay received in 1928 Nobel Prize in medicine for his identification of lies as the transmitter of epidemic typhus. Then Howard Taylor Ricketts from 1879-1910, he was working in University of Chicago, and he worked on Rocky Mountain spotted fever, and he died of house-borne typhus. And in fact, this Rickettsioses name came from this scientist, and in honor of its name. So what is Rickettsial organism? It belongs to a group of alpha protobacteria, a gram-negative cocobacilli, are obligatory intracellular parasite of eukaryotic cells. Currently, there are about 26 Rickettsial species have been validated and identified. And these species have a different kind of a transmission, and to some extent may cause some varied clinical illnesses. There are two groups basically in Rickettsioses. One is spotted fever group. We call it SFG. And there are about 20 validated species based on Rickettsiae conorae and Rickettsiae. Then the typhus group. They are caused by, again, the Rickettsiae. There are a large number of Rickettsiae coming on typhus group. And one type is scrub typhus, is well known to us, but that is caused by Rickettsiae, but somewhat different. It's named as Oriontia under genus. So coming to the disease transmission, all Rickettsioses exist as zoonoses and vector-borne diseases. Primary host is arthropods, secondary host vertebrates. Under arthropods, they could be vectors, reservoirs, or amplifiers. And non-arthropods are ticks. Ticks are the commonest, then the flea, mite, and louse. This Rickettsial pathogen multiply within the arthropods' intestinal cells. Human transmission through arthropod saliva, feces. So within humans, it goes to lymphatics, endothelium, and white cells. And here, slide shows you ticks, then the mites, even the lice. Coming to the different Rickettsial diseases, the scrub typhus, murine typhus, the spotted fever group, and endemic typhus you see in the left-hand column. If you take scrub typhus, the agent is Oriontia tissue gamoshi. Larval trombicular impaired grass. In single, it is called illoc. And from there, it gets into the host, maybe animal host or human. In case of murine typhus, it's Rickettsiae typhi, and vector is rat flea, and the mammal is again ratus. Coming to spotted fever group, it's Rickettsiae, conorae, japonica, honai, and the vectors are commonly ticks, and these reservoirs are rodents, dogs, or rabbits. Then coming to epidemic typhus, here the reservoir is human. There is one reason that epidemic typhus is not existing currently in the world. Rarely there are epidemics in African countries, but this was really a major problem in the old world, in concentration camps, where there are people who are living together. Coming to the different kind of Rickettsial diseases, there are numbers, large numbers. They are well-reputed ones are Rocky Mountain spotted fever caused by Rickettsiae, Mediterranean spotted fever by Rickettsiae conorae. Like that, this number of Rickettsial diseases are there, as well as their pathogens are identified. But in Sri Lanka, we haven't identified the specific rickettsial agent of the Rickettsioses in Sri Lanka. Coming to the pathogenesis, once the rickettsial pathogen get into the human body, it is an intracellular organism. It blood and leading to like explosive deposit. Also delayed. The vasculitis is the main mechanism producing the disease in all organ system. Come into clinical diagnosis. There's a triad. There's a triad. High fever, headache, skin eruptions. Skin eruptions are rashes. They are commonly maculopapular erythematous. I'll show you some pictures later. And other point is there's a rapid defervescence to appropriate antibiotics. Not all the antibiotics. The antibiotics to which it responds are doxycycline, then chloramnicol, etc. However, clinical manifestations could be non-specific or atypical. This slide shows you the temperature pattern, that is remittent, irregular type of temperature that rapidly settles down within 24 hours to 48 hours with appropriate antibiotics. Also, you see Eshka, that is the site, the bite of the vector happening and introduction of the pathogen. Then in the hands and legs, you see maculopapular rash. Also in the legs, you see swollen ankle joints in case of spotted fever. In some situations, this rash in the body, the skin, may progress into a gangrene or necrosis. It's a necrosis. And we commonly use a term, but it's called fern leaf necrosis, because these necrotic patches have a kind of a leafy appearance. So name given is fern leaf necrosis. Not all patients getting it. It's a kind of a rare complications in Rickettsioses. Come to laboratory diagnosis, confirmation need serological testing. Over the decades, there's one test available, that is Wheel-Felix test. But that is an obsolete test because it is having low sensitivity and specificity. But the most appropriate serological test is immunofluorescence antibody test. That's a reference technique. Commonly, it's available in reference laboratories. In Sri Lanka, only in 2 places, this test is available. One place is Peradeniya, Faculty of Veterinary Medicine. There are some more specific serotests available, like this Western blot and cross-absorption technique. Other techniques like cell cultures and the PCR-based diagnosis are possible on skin biopsies or swabs from Eshka. But the overall yield is very much with PCR. So this is a indirect immunofluorescence antibody test that is the gold standard serodiagnostic technique in Rickettsioses. Then I'll come to the Rickettsioses in Sri Lanka. That is what is important for us at the moment. The history of Rickettsioses in Sri Lanka runs long way back. To date, it is seen in many regions in the island, as I shown you. And there are 3 known disease entities. That's also comes later. And the patients are having wide array of symptoms. What is the first record of Rickettsioses in Sri Lanka? That appeared as first record of tropical typhus in Sri Lanka. Dr. Lucian de Silva, born in 1877, he was a surgeon as well as obstetrician. He wrote his autobiography. In his autobiography, he clearly mentioned he suffered from tropical typhus that was in 1935. He had pyrexia of unknown origin with vaccine and waning clinical course. And one occasion he was almost semi-conscious, and it subsided its own without antibiotics. But the blood sample which was sent to a lab in Malaysia, they have confirmed it was as tropical typhus. So that was the earliest evidence of Rickettsioses in Sri Lanka. Then there are publications. Those were available from 1938, published in BMJ, Ceylon branch. So publications appeared till 1943 during Second World War time. There were about 750 soldiers got scab typhus in Ambilipitia. After 1943, no significant records of Rickettsioses published in Sri Lanka, except one study in 1976, serological study, where this serosurvey showed presence of Rickettsial antibodies. So up to 2000, it was kind of a dark era without publications. So in latter 1900, latter part of 1900, even in medical schools, the students were taught as Rickettsiae, something alien infection, not in Sri Lanka. In Navalapitiya in 1991, I was serving there as a physician, and I came across patients with fever, rash, and in hindsight, I thought they were Rickettsiae and treated them with tetracycline. They recovered. Even one patient developed necrosis. So that knowledge carried forward to Peradeniya. In 1999, a systemic study was carried out. As IFU is not available in Sri Lanka, he sent the blood samples to Japan and Thailand and got confirmation of the diagnosis of 60 samples. And according to these results, the commonest was spotted fever group, then the typhus, even murine type can be found. So this came as a publication in 2003 as the first publication of re-emergence of Rickettsioses in Sri Lanka. Since 2002, there's a regular record of cases, even happening up to now. This slide shows only up to 2007. So finding was Rickettsioses are common in Central Hills, and Navalapitiya was the epicenter in 90s. So when you consider this spotted fever rickettsial infection, there's a belt of spotted fever Rickettsioses epidemiologically in Sri Lanka. That is the western slope of Central Hills, spreading from Navalapitiya to Kekor. So the spotted fevers are commonly transmitted by ticks. Ticks are there in many animals like dogs, even pigs and so on. But if you take Rickettsioses in other parts of the hilly area, in the plains, publications started coming from 2008. My colleague, Professor Ranjan Premaratne, he published a paper from Western Province showing that predominance of spotted fever in some cases, predominance of scrub typhus, and some cases of spotted fever. So scrub typhus is quite common in the dry zone. Is transmitted in Peretta grass. So this study published from Galle, southern Sri Lanka, and according to them, even by 2007, all three types of Rickettsiae are prevailing in the southern sector: the scrub typhus, spotted fever, as well as murine typhus. So, what are the clinical spectrum of Rickettsioses? The common is the fever, headache, rash. That triad is common among children and young adults. But towards the elderly age group, the picture becomes very atypical, coming with obscure neurological manifestations, pancytopenia, and mimicking phagocytic syndrome, or acute hearing loss, commonly in scrub typhus, major joint arthritis, spondyloarthritis, tendinitis, varying presentations with cutaneous manifestations, facial palsy, that means mimicking Bell's palsy, and apathy in elderly, with inactivity. So this is a spectrum of atypical manifestations. In case of acute spotted fever group, patient can go into organ failure, liver failure, thrombocytopenia and DIC, severe cutaneous vasculitis, acute neurological manifestations like meningitis, encephalitis, and so on, even Guillain-Barré syndrome. So this is an elderly gentleman who is showing extrapyramidal manifestations. He has tremor, rigidity, like Parkinson's picture. Another problem is rickettsial infection pregnancy. It is not uncommon. Pregnant mothers contracting rickettsial infection. When this happens, there's a big issue, how to treat, because doxycycline, chloramnicol, these drugs may be harmful to fetus. So because of that, it's a challenge to treat rickettsial infection pregnancy because a limited number of options are available. Only safest antibiotic, which has anti-rickettsial effect is azithromycin. But azithromycin is mild. So these are the antibiotics commonly used in rickettsial infections: tetracycline, doxycycline, chloramnicol, 3 drugs. Ciprofloxacin may be having mild effects as well as azithromycin. But in Rickettsiae, as I mentioned earlier, because of vasculitis, steroid has a place. Sometimes it is life-saving. It reduces the organ dysfunction. So it's good to combine steroids when necessary, when the antibiotic alone may not be effective. So what are the challenges in this topic of Rickettsioses or Rickettsial problem in Sri Lanka? Awareness, because now of course awareness has improved, but maybe 20 years back, there's a lot of misdiagnosis happening due to lack of awareness. So awareness needs to be improved. Missing the diagnosis, that happens when the atypical pictures are coming because of large clinical spectrum, sometimes presenting with PUOs, or rash may be totally absent. So Rickettsiae causing morbidity like and so on. Also, mortality. If there's a delay in diagnosis or missing diagnosis, patient could succumb to illness due to multi-organ dysfunctions. Another major drawback is confirmation of diagnosis, as laboratory diagnostics are very much restricted. So only in 2 places in Sri Lanka, this laboratory diagnostic technique, this serology, IF, indirect immunofluorescence antibody available, even that is costly, and there's a limitation of availability. So in summary, in Sri Lanka, Rickettsioses has re-emerged and now very much well established. There are 2 predominant types, SFG, the spotted fever group in Central Hills, and the scrub typhus in the lowlands. Atypical presentations are common, and there's a modality. So effective antibiotics are doxycycline, chloramicol, and antibiotic resistance could happen. So there's a change in ecology in Sri Lanka, formerly in Central Hills. So that would have contributed for emergence of Rickettsioses. Ladies and gentlemen, thank you very much. I tried over these 20 minutes to give you some overview of Rickettsioses, mainly about Sri Lanka, as well as some touch on the world literature. So finally, again, I wish to thank Sri Lanka College of Physicians for this invitation, and I wish very best for the sessions.
Okay, thank you very much.
Thank you very much.
Thank you very much for that excellent overview of Rickettsial diseases in Sri Lanka. Thank you. And I do hope that you will stay with our question sessions, and let's move on to the questions.
Thank you. We have a few questions, so we'll just rush through them because we are at the end of our time limit. And I think we need to apologize to our listeners for the rather poor connection, especially in the last presentation. There were several moments when it was not very clear. Well, let's move on to Dr. Nadika Janage. I have one question for you from one of our audience. Does mycophenolate therapy increase cytomegalovirus infection risk?
Yes, I told that earlier, the CMV infection is mainly controlled by cell-mediated immunity, not by the antibody, because we have seen even in the presence of IgG against CMV, still infection can go on and can have adverse effects. So mainly it is cell-mediated immunity suppression is the main role for adverse outcomes. So therefore MMF play a role in adverse outcome with CMV in transplants. The main thing is it is not only one factor. The overall outcome is as a result of several factors, including the suppression and CMV zero status before the transplant and other many other things. So therefore, we have to consider all. And in transplants, we might need to consider prophylaxis if possible. In case of bone marrow transplant, we can't consider prophylaxis because we want to engraft new marrow. So therefore, as these drugs are very toxic for marrow, we can't go for prophylaxis in bone marrow. But in solid organ transplants, considering all risk factors, it is possible to consider antiviral prophylaxis. And MMF is also one single independent risk factor for CMV infection and adverse outcome.
Thank you. There are some questions for Professor Kulratne, but unfortunately we have lost the connection with him. So I do apologize, we won't be able to entertain those questions, some of which are very interesting actually, but that's the way it is with technology. Well, ladies and gentlemen, we have come to the end of the last parallel session of our annual conference this year. So just a few announcements before we go away. One is that the Sri Lanka College of Physicians is planning to bring out the recordings of these presentations, and they'll hopefully be able to post them on their website in a few weeks' time. So do keep watching that space. and the winners of the various competitions, they will be informed in due course about their victories. So thank you so much indeed for your company. We have, I hope that we have had a good conference for you. And thank you for joining us, and all the very best to you. And let me now close the sessions down. Thank you very much.